Good morning, everyone. I would have really loved to be there in person to see you all, especially in Boston, a city that's very dear to me. But I unfortunately needed to stay back to be with family. So I thank you for your understanding. I have no disclosures. So, endocardial pacing in the systemic circulation. What is this all about? That's the first question we will tackle. And then we will delve into approaches to lead implantation, related concerns, and then we will conclude. So the concept of placing endocardial leads in the systemic circulation is actually not new at all. In fact, Robert Gordon back in 1982, so over 40 years ago, described a case series of 6 patients who had transmural atrial leads placed in the left atrial appendage during open heart surgery. And essentially, the approach was to create these atrial stab incisions to control the bleeding with purse string sutures, and then to place the tip of the lead at the tip of the left atrial appendage with or without anchoring sutures. And this technique of transmural atrial pacing was later applied to patients with congenital heart disease as well. And in this series of patients from 1999, 11 out of the 18 patients had Fontan surgery. And in most of these patients, the leads were placed in the pulmonary venous atrium, in part because these patients were undergoing Fontan revision and a large portion of the right atrium was being resected. And so if you look at acute chronic thresholds, they look really quite reasonable. Now, the concept of endocardial pacing in the systemic circulation resurged with the advent of endocardial pacing for cardiac resynchronization therapy. And there were strong proponents of this approach. And the purported benefits that they claimed were, first of all, there was a wider choice of pacing sites because when you pace from a coronary sinus, you're limited by the anatomy of the coronary sinus and its branches. Whereas if you put a lead on the endocardial surface of the left ventricle, you have a wide choice of pacing sites. Endocardial pacing also provides more physiological activation because you're depolarizing the ventricle from endocardium to epicardium, which is also thought to be less arrhythmogenic. It also provides superior hemodynamics. If you look at the maximum rise in LV pressure, it's greater with endocardial than epicardial pacing. It results in lower thresholds. There's less risk of phrenic stimulation. There's a lower incidence of lead dislodgement because you're actively fixing the leads on the endocardium as opposed to placing passive leads in the coronary sinus, and possibly a reduced proportion of non-responders. And several different techniques were described to get leads into this systemic ventricle. There was a transeptal atrial approach, a transeptal ventricular approach, a surgical transapical approach, and more recently, the wireless approach that we will discuss as well. Now, of course, for our patients with congenital heart disease, we also always need to display some creativity, and several interesting case reports and case series have described approaches to implanting leads in the systemic circulation. And so this is one case report where the patient had complex anatomy with an extracardiac conduit Fontan, and they resorted to using a printed 3D model of the rib cage and heart in order to guide the surgical approach. And what they did in this particular case was they resected this costochondral junction of the fourth rib and then directed a needle in that area medial to the extracardiac Fontan to reach the pulmonary venous atrium. And other creative approaches in our patient population include placing leads across fenestrations in Fontan baffles. So on the left here, you see a Fontan conduit and 2 leads going across that baffle into the pulmonary venous atrium and the systemic ventricle. And on the right, you see a transhepatic approach. This was a patient with a Kawashima type Fontan where they punctured in the hepatic vein to place a lead in the systemic ventricle. Other creative approaches include placing leads in venous collaterals. So this is a patient who had a persistent tortuous left superior vena cava that drained in a coronary sinus, and it was a sort of pop-off to the Fontan circulation. And here you see that vein being cannulated and leads being placed in the systemic ventricle and in the pulmonary venous atrium. Now, there's also a transpulmonary atrial pacing approach that's been described both for the right pulmonary artery and left pulmonary artery. This is a description from Jeremy Moore of transpulmonary pacing through the left pulmonary artery, and he beautifully here demonstrates the anatomy. You can see the pulmonary artery and how that courses just above the roof of the left atrium. And so the technique described here was to puncture across the floor of the left pulmonary artery, and then again puncture through the roof of the left atrium, just posterior to that left atrial appendage. And this patient actually had a catheter ablation procedure, and so what they did is placed the mapping catheter at the site of interest to help direct the transpulmonary transatrial punctures and position of that atrial lead. Now, you're all probably familiar as well with this newer wireless systemic ventricular pacing system, where a small tic-tac-like device that's a receiver pacing electrode is placed through a retrograde aortic approach and into the systemic ventricle. So it's endocardial pacing in the systemic ventricle, but without a lead actually in place. And this is combined with a subcutaneous battery and transmitter that are capable of sensing impulses that come from pacing of the right ventricle to then synchronize the left ventricle by sending ultrasound pulses to this receiver that then converts that ultrasound energy into electrical energy to pace the systemic ventricle. Now, with leads in the systemic circulation, what is the primary concern? I'm sure you've all guessed it. It is lead thrombosis and thromboembolic complications. And there is no doubt in my mind that leads are really highly thrombogenic. I mean, if you look at this case series of transesophageal echocardiography in patients with endocardial leads, clot is detected in 32% of patients. And the mechanism is thought to be, predominantly related to a foreign body type reaction with inflammation, fibrosis, and thrombus that then propagates along the lead. But there can also be a component of endothelial injury due to the lead and also of increased blood turbulence due to that lead. Now, if you look at the autopsy series, the situation looks even worse here, with 48% of atrial leads having thrombus and 33% of ventricular leads having thrombus. And the most common site for thrombosis is in the atrium, and that's even true for ventricular leads. So it's that portion of the lead that traverses the atrium before going across the tricuspid valve. Why? Because the atrium is a lower flow, higher stasis chamber. Now, what if you inadvertently place an endocardial lead in the systemic circulation? Well, this case series describes that in these patients, 37% of them will have a stroke or TIA, hence the recommendation to remove and reposition a lead that's placed in the systemic circulation. But what if you purposely place the lead in the systemic circulation? So you know about it, but then you aggressively anticoagulate your patient. And this was done, intentional systemic endocardial pacing in 50 patients. 44 of them had atrial transeptal approaches to place these leads. 6 had surgical transapical approaches, and they were all anticoagulated with targeted INRs between 3.5 and 4.5. But during a median follow-up of 24 months, 14% of patients had stroke or TIA. And this is an underestimate because 20 patients actually died. And so if you look at the at-risk population, 23% of patients actually had a stroke or TIA. Now, what if you take this a step further and you intentionally place leads in the systemic circulation, and you do it in the context of a prospective study with really very well-defined, rigorous follow-up? Well, this was done in the prospective all-sync study, where endocardial leads were successfully implanted in 118 patients from 18 centers with targeted INRs between 2 and 4. And here, over a mean follow-up of 17 months, 11% had strokes or TIAs. So 11% is really quite substantial if you consider that follow-up is less than a year and a half. And so the results of this prospective all-sync study pretty much threw a cold shower to the concept of endocardial pacing for cardiac resynchronization therapy. And I don't think that this notion of high thromboembolic risk with leads placed in the systemic circulation comes as much of a surprise to us in the congenital world, where we've known for quite some time that if you place leads in a non-systemic circulation, but in the presence of an intracardiac shunt, the risk for systemic thromboembolic events increases nearly threefold. And similar data was reported by the Mayo Clinic, just looking at endocardial leads in the setting of PFOs, where in multivariable adjusted analyses, the risk for stroke or TIA was increased again here about threefold. And although I think we're still coming to grips with what to do with the issue of PFOs, I think the literature is really quite consistent and clear that if you place an endocardial lead in the systemic circulation or in the non-systemic circulation, but in the presence of an intracardiac shunt, there is a substantial increase in risk of systemic thromboembolic complications. And I think the data that I've shown you also suggests that anticoagulation somewhat mitigates this risk. When leads are placed in the systemic circulation knowingly and patients are anticoagulated, the risk for systemic thromboembolic events does seem to be lower than in non-anticoagulated patients. And I believe that the data from Boston looking at atrial pacing leads in the Fontan circulation are likewise consistent with this notion that anticoagulation has some effect, but that there remains an important residual risk. So these leads in this Boston study were not placed in the systemic circulation. It was, leads again in the Fontan circulation, but they specifically looked at the impact of aspirin or anticoagulants in terms of reducing this risk. And in multivariable analyses, they found that aspirin had no detectable effect, warfarin had no detectable effect, warfarin or a DOAC combined, no detectable effect, but there did appear to be a reduction if you considered aspirin, warfarin, or DOAC. So again here, the notion that anticoagulants probably offer some protection. And so if you were to anticoagulate patients with leads in the systemic circulation or in the presence of an intracardiac shunt, well, which anticoagulant should you choose? There really is no, strong comparative evidence looking at DOACs versus warfarin, but there certainly have been some concerns raised over the efficacy of DOACs in preventing thrombus on foreign material. The REALIGN trial was prematurely interrupted because dabigatran, when compared to warfarin, resulted in an excess in thrombosis in patients who had mechanical valves and also an excess in bleeds. And there are some case reports of lead thrombosis developing in patients despite DOAC therapy. And in this case, a pacemaker was implanted, and since the get-go, the patient was on apixaban, and this image is 2 years later, so that's 2 years of apixaban therapy, and you see thrombus developing on that atrial portion of the lead. And this patient was then switched to warfarin, and 30 days later, that thrombus had completely resolved. And there are some similar reports on rivaroxaban as well. And so, pending further data, my preference in terms of anticoagulation for lead-related thrombosis is warfarin for the time being. But of course, warfarin has its own issues. This is a study that is now online ahead of print. We conducted this multi-center study looking at 567 patients with congenital heart disease on vitamin K antagonists. We looked at 12,866 INRs during a follow-up of 12 years. And quite surprisingly, the proportion of time that our patients spend in the therapeutic range is a meager 42%. I mean, so 58% of the time, our patients are not in the therapeutic range. And this certainly has repercussions regarding thromboembolic and bleeding complications. And while I'm certainly not a fan of placing leads in the systemic circulation or in the presence of an intracardiac shunt, I think we need to be, careful about making blanket statements because, here I am with my team implanting a leadless AV synchronous pacemaker in a patient with Eisenmenger syndrome of all conditions. And so clear right to left shunting. And this was after carefully weighing risks and benefits of all, potential options. It was felt to be the least risky alternative. So I'm certainly not advocating putting in leadless devices in Eisenmenger syndromes, but we do need to individualize therapy and consider risks and benefits. Now, quickly circling back to that transpulmonary approach that I previously described to you, the UCLA and Vanderbilt team got together to publish a small case series where they describe a modification of this approach. And so now the approach they recommend is rather than going inside the systemic circulation, the lead is placed on the outer surface or the epicardial surface of the left atrium. So again, they're going through the pulmonary artery, but not through the atrium in order to avoid the complications associated with leads placed in the systemic circulation. Now, there still remains a portion of the lead in the Fontan baffle, but none in the systemic circulation. And if you're wondering, well, where exactly is this lead going? Through a pulmonary artery on top of an atrium. It's in a space called the transverse pericardial sinus. So behind the pulmonary artery and aorta is this transverse pericardial sinus. It allows physiologically the aorta and pulmonary artery to expand during systole. It's certainly a space well known to cardiac surgeons. They can cross clamp the aorta from there or even ligate the pulmonary artery. And if you follow that left pulmonary artery, you'll note that just below it, you're on the surface of the left atrium. So the lead is actually positioned on the visceral pericardium of the roof of the left atrium. So, ladies and gentlemen, to conclude, endocardial leads are highly thrombogenic. I think there's no question about that. Avoiding endocardial leads in the systemic circulation or in the setting of an intracardiac shunt should generally be preferred, although risks and benefits of alternative pacing approaches should be carefully weighed. Anticoagulation is recommended if it is decided to place an endocardial lead in the systemic circulation or if it is left in the presence of an intracardiac shunt. And here my preference is warfarin, although there's not a whole lot of data to back that claim. And finally, the transpulmonary epicardial approach to atrial pacing in Fontan patients merits further study. Thank you very much for your attention.